Welcome to the Deep Dive, your shortcut to cutting through information overload and getting straight to the insights that truly matter. Today, we're embarking on, well, a really crucial deep dive for you, especially if you're a first-year medical student. We're getting into a topic that underpins so much of what you'll encounter: neoplasms, invasion, and metastasis. We'll trace that extraordinary and, frankly, terrifying journey from just a single rogue cell to potentially widespread disease.
Yeah, it's definitely a journey steeped in some pretty complex biology, but our mission today is really to demystify it. We'll break down the fundamental concepts, give you clarity, and maybe most importantly, some memorable anchors and metaphors. So this vital knowledge actually sticks as you build your medical foundation.
Exactly. We've sifted through your sources, pulled out the essentials, and we're ready to guide you through it. So yeah, let's get started. Okay, to kick things off, let's unpack some foundational ideas first. We hear terms like tumor and cancer all the time, right? But they're often used, well, a bit loosely. So first question, can a lump in the body be totally harmless? And what's the precise medical difference between a tumor and a neoplasm?
That's a perfect starting point because, precision in medical language is just paramount. Fundamentally, neoplasia describes uncontrolled abnormal cell growth. Just imagine a single cell that picks up a series of genetic mutations, and these allow it to start proliferating, growing excessively, and crucially, autonomously. Basically, it's growing independently of the body's normal signals.
Okay, growing on its own terms.
Exactly. So a neoplasm is the resulting abnormal growth of cells that persists even after whatever triggered it is gone. And here's a really critical takeaway for you. Once neoplasia begins, it is irreversible. It's like a one-way street for those cells. There's no turning back. Irreversible, okay. So an abnormal, persistent growth. What about the broader term then, tumor? Is that the same thing? Not quite. A tumor is really any clinically detectable lump or swelling. Could be anything. For instance, an abscess or, a hematoma from a bruise, even the swelling from a healing bone fracture. Technically, those are all tumors, but they're non-neoplastic. They have a cause, and they usually resolve. A neoplasm is just one specific type of tumor. Does that make sense?
Yeah, it does. So tumor is the umbrella term.
Right. And to complete the picture, cancer is specifically any malignant neoplasm, the dangerous kind.
Got it. Neoplasm is a type of tumor. Cancer is a type of neoplasm. Okay. Now, you mentioned neoplasia is irreversible, but are there any cellular stages before that point, where things can still turn back?
Absolutely. And this is where dysplasia becomes such a key concept to grasp. Dysplasia is basically a pre-neoplastic alteration. The cells show disordered growth, tissue organization is messed up, but crucially, it is reversible.
Ah, okay. So there's a chance for intervention there.
Precisely. Think of dysplasia as a kind of cellular crossroads. The cells are heading down a path towards potential neoplasia, but they haven't crossed that irreversible threshold yet. They can still potentially be guided back to normal function. We see this clinically in things like cervical dysplasia, which we screen for as CIN or Barrett's esophagus or those adenomatous polyps in the colon. These are situations where, careful monitoring or intervention can actually prevent progression to cancer.
That cellular crossroads metaphor is really helpful. Okay, so once we do have an irreversible neoplasm, how do we distinguish between the relatively, let's say, good ones and the genuinely bad ones? Let's maybe use a simple analogy here. Think of it like a good neighbor versus a bad neighbor.
I like that. That analogy works beautifully. So the good neighbor, that's your benign neoplasm. These tumors, they tend to stay within their own property lines, so to speak. They're typically well-defined, often encapsulated, clearly separated from the surrounding tissue. They usually grow quite slowly. Their cells are well-differentiated.
Meaning they still look a lot like the original tissue.
Exactly. They closely resemble their tissue of origin. And importantly, they do not invade nearby tissues or metastasize, spread to distant sites. Recurrence after surgical removal is pretty rare. Now, while they're generally not dangerous in themselves, a benign tumor in a confined space, like, say, a benign brain tumor, can still cause serious problems just by creating pressure.
Right. Location, location, location. Okay, so that's the good neighbor. Then there's the bad neighbor, the truly dangerous malignant neoplasm.
Exactly. The bad neighbor is invasive. It just doesn't respect boundaries. These neoplasms grow irregularly, often without a proper capsule, and they're poorly demarcated. It's hard to tell where the tumor ends and normal tissue begins. This invasive behavior, actually, is why the term cancer comes from the Greek word for crab crikinos. It refers to its sort of claw-like spreading nature.
Huh, the crab analogy. That definitely sticks.
Yeah. And malignant neoplasms, they tend to grow rapidly. Their cells are poorly differentiated, sometimes completely undifferentiated or anaplastic. They look quite abnormal under the microscope, with frequent, often chaotic cell division. They're also often aneuploid, meaning they have an abnormal number of chromosomes, which contributes to their instability. They frequently ulcerate, break down, and bleed, and unfortunately, recurrence after surgery is common because of that invasive nature. It's hard to get it all out.
That really paints a picture of uncontrolled, aggressive growth. Now, when we talk about how abnormal these cells look, how do we sort of grade that severity? And how does that relate to how far the cancer has spread?
Right, we use three main descriptors here, and it's important to keep them straight. First is differentiation. Like we said, this tells us how much the cancer cells still resemble their normal tissue of origin. Well differentiated looks quite normal. Poorly differentiated looks very abnormal. Then there's grade. This assesses the degree of differentiation and the rate of cell division, basically, how aggressive the cells look. So a high-grade tumor is poorly differentiated and usually more aggressive. And finally, there's stage. This describes the extent of the cancer in the body. Its size. Has it invaded locally? Has it spread to lymph nodes? Has it metastasized to distant organs? Stage is often the most critical factor for prognosis and treatment planning.
Differentiation, grade, state. Okay, got it. So let's quickly circle back to that first question. Can a lump be harmless? And what's the core difference again between a tumor and a neoplasm?
Yes, absolutely. A lump can be harmless. It can be non-neoplastic, like we mentioned, an abscess, a hematoma, a fracture callus. Or it could be a benign neoplasm, which, while it's an abnormal growth, doesn't invade or spread dangerously unless its location causes problems. The crucial distinction is that a neoplasm is a specific type of tumor characterized by that abnormal, persistent, irreversible cell growth.
Okay, that clarifies things nicely. Now let's talk about names. Medical terminology can feel like a maze sometimes, right? Especially with neoplasms. There seem to be rules, but then loads of exceptions. Let's talk about naming these growths.
Yeah, the nomenclature can definitely be tricky, but there are some general rules that help most of the time. For benign neoplasms, the general rule is pretty simple. They usually end in the suffix -oma. So think fibroma for fibrous tissue, osteoma for bone, papilloma for finger-like projections, adenoma for glandular tissue, and angioma for blood vessels.
Right. Oma generally means benign.
Generally, yes. Now, when we move to malignant neoplasms, things get a bit more specific based on the tissue type. Malignant epithelial cancers, which are the most common type of cancer overall, end in carcinoma. So you have squamous cell carcinoma, adenocarcinoma, and transitional cell carcinoma, also called urothelial carcinoma. Malignant stromal or connective tissue cancers, things like muscle, bone, fat, these end in sarcoma, like fibrosarcoma, rhabdomyosarcoma for skeletal muscle. Stroma just means the structural or connective tissue of an organ.
Okay, carcinoma for epithelial, sarcoma for stromal. But here's where it gets really interesting and maybe a bit confusing for exams. There are some really crucial exceptions where that oma suffix actually means it's malignant, not benign at all. To help you remember these critical exceptions, we've got an acronym, a little anchor for you. MLSGMPA. Can you walk us through that?
Yes, this acronym is your key to remembering the big malignant omas. M is for melanoma, a malignant tumor of melanocytes, the pigment cells of your skin, highly malignant. L is for lymphoma, malignant proliferation of lymphoid tissue. S is for seminoma, a common malignant tumor of testicular germ cells. G is for glioma. This refers generally to malignant tumors of glial cells in the brain. M is for mesothelioma, a malignant tumor arising from the mesothelium, the lining of body cavities like the pleura. P is for plasmacytoma, a malignant plasma cell tumor, often part of multiple myeloma. And A is for astrocytoma. Now, some astrocytomas are low-grade, but high-grade astrocytomas are highly malignant gliomas, often just called glioblastomas. So MLSGMPA, definitely worth committing those to memory.
Absolutely. Melanoma, lymphoma, seminoma, glioma, mesothelioma, plasmacytoma, astrocytoma. Got it.
And there are a few other malignant categories to flag too, right, like plasmatoma. Right. You'll see maldoblastoma used for malignant embryonal tumors, the kind that arise from primitive cells, mostly found in children. Think neuroblastoma, retinoblastoma, hepatoblastoma in the liver, nephroblastoma in the kidney, and of course we have leukemia, which is malignant disease of bone marrow and blood cells, and myeloma, which specifically refers to malignant plasma cell tumors, usually in the bone marrow.
Okay. That covers a lot of the key naming conventions and the tricky exceptions. Now, let's move on to what really makes malignant neoplasms so dangerous, their ability to invade and metastasize.
Mm,
This is where our bad neighbor analogy really comes into play. This is where it becomes a true threat, spreading disease potentially throughout the entire body.
indeed. Invasion and metastasis are the hallmarks of malignancy and ultimately the cause of most cancer deaths. Metastasis, just to define it clearly, is the spread of malignant cells from their primary site, where they started, to a new, non-contiguous secondary site somewhere else in the body.
And it's worth hammering this home again. Benign tumors do not metastasize, only malignant ones. Right.
Okay, so here's a thought-provoking question for you to ponder as we go through this next section. What exactly makes a cancer cell decide to leave its, cozy home, break free, and embark on this incredibly dangerous road trip through the body? It sounds like a ridiculously complex undertaking for just a single cell, doesn't it? We'll circle back to this.
It really is a remarkable and perilous multi-step journey for the cell. Fundamentally, it involves three major phases. First, the cells have to grow and successfully invade the tissue at the primary site, break out of their original location. Second, they need to gain access to and survive within a transport system, usually the blood vessels or lymphatic vessels. And third, they have to exit that transport system, arrive at a new location, and successfully grow there, forming a secondary tumor. And a critical point. At every step of this process, these cells must somehow evade destruction by the host's immune system. The whole process is actually incredibly inefficient. For the cancer cells themselves, most don't make it. But when it is successful, the consequences are devastating. Inefficient, but devastating. Wow. Okay, so this isn't just a cell deciding to wander off. You mentioned invasion. That sounds like it requires some pretty dramatic cellular changes. What key transformations allow a cancer cell to actually pull off this great escape?
Yeah, it's a profound transformation. A key process involved here is called epithelial to mesenchymal transition, or EMT. Think of it as the cancer cell putting on a cellular disguise. Epithelial cells, which are normally tightly packed and stationary, transform into a state that resembles mesenchymal cells, cells that are naturally more mobile and evasive. There are three main functional alterations that enable invasion.
Okay, what are they?
They have to alter their adhesion. They need to detach from their neighboring cells. A key molecule here is E-cadherin, which acts like cellular zipper. They essentially unzip themselves from their neighbors by reducing E-cadherin. They also change how they attach to the surrounding extracellular matrix, the scaffold around cells, by altering proteins called integrins. So they let go of their usual anchors.
So they unstick themselves, basically. What's next?
Second, they need to perform stromal proteolysis. They have to digest their way through barriers, like the basement membrane, which normally contains epithelial cells. They do this by secreting enzymes, particularly a family called matrix metalloproteinases, or MMPs. These enzymes degrade the proteins of the basement membrane and the surrounding connective tissue, clearing a path. And malignant cells can be quite clever here. They often coax nearby normal cells, like fibroblasts and immune cells, into helping them, creating a supportive cancer niche that supplies growth factors and even more of these proteases.
Wow, they recruit help. Okay, so they detach, they digest. What's the third part?
Third, they acquire altered motility. Once the path is clear, they need to be able to move. This involves changes in their internal scaffolding, the actin cytoskeleton. These changes allow the cells to actively walk or migrate through the spaces they've just created.
Okay, that's a lot to remember. To help anchor those crucial invasion steps, let's try another acronym. DDLMD is for disconnect, detaching from neighbors, messing with E-cadherin. D is for dig, degrading barriers, using those MMPs. L is for let go, losing adhesion to the extracellular matrix, changing integrins. And M is for move, migrating through the new space, using that actin cytoskeleton. DDLM, disconnect, dig, let go, move. That's like the cellular invasion checklist, right?
That's a fantastic anchor. DDLM, perfect.
Huh.
So once these cells have successfully invaded and are on the move, they need a way to travel longer distances. The body essentially offers three major routes, or highways, for metastatic spread. You can remember these as the three L's and a B.
Okay, the three L's and a B, what are they?
The first L is lymphatics. Cancers arising from epithelial tissues, carcinomas, very commonly spread via the lymphatic system first. They often travel to the regional lymph nodes, draining that area. The second L is local spread, which includes transcoelomic spread. This means cancer cells spread directly into and across body cavities that are lined by mesothelium, like the pleural cavity around the lungs or the peritoneal cavity in the abdomen. They travel via the fluid in these spaces. And then there's the B blood, also known as hematogenous spread. Sarcomas, those cancers of connective tissue, tend to favor this route early on. Carcinomas will also use the blood route, often after they've already spread via the lymphatics or sometimes primarily.
Lymphatics, local transcololomic, and blood. The 3 L's and a B. Got it. Now, let's zoom in on that journey through the bloodstream. It sounds incredibly hostile. Imagine being a single cancer cell trying to survive. In there, you've got sheer forces from the blood flow, turbulence, plus an immune system actively hunting for anything that looks out of place. How on earth do they survive that?
It's an incredible feat of survival, you're right. We call these cells circulating tumor cells, or CTCs. And they're incredibly rare, like finding a needle in a haystack, maybe one CTC per million, or even 10 million normal leukocytes. Their challenges are immense, as you said. The physical stress of blood flow can tear them apart. Immune cells like natural killer, NK cells, are primed to attack them, and they lack a solid surface, a substratum, to adhere to, which many cells need to survive.
So how do these stealth invaders manage to overcome such overwhelming odds? They must have some kind of trick up their sleeve.
They do have a remarkable survival strategy. It involves creating what we can maybe call a platelet invisibility cloak. The CTCs can actually trigger the coagulation cascade around themselves, releasing factors that cause platelets to aggregate and form a protective shield, like little microthrombi around them.
Wow, a cloak made of platelets.
Essentially, yes. This platelet shield does two crucial things. First, it physically protects the CTC from the sheer stress and turbulence in the bloodstream. Second, and perhaps more importantly, it helps them evade immune detection. Platelets carry MHC class I molecules on their surface, and by coating the CTC, they can essentially disguise it, making it harder for NK cells and other immune cells to recognize it as foreign or dangerous. Detecting these CTCs in a patient's blood is now a really exciting area of research. It holds potential for early diagnosis, predicting prognosis, and even guiding treatment choices.
A platelet invisibility cloak.
Nah.
That's amazing. Okay, so thinking back to our earlier question, what actually makes a cancer cell leave its cozy home and embark on this dangerous road for you?
Well, it comes back to that fundamental process we discussed. The epithelial to mesenchymal transition, EMT. It's that series of cellular transformations, changing adhesion molecules like E-cadherin and integrins, producing proteases like MMPs to degrade barriers, and acquiring that increased motility through changes in the actin cytoskeleton. All these steps allow the cell to detach, break through its local boundaries, invade, and then gain access to those transport routes like the blood or lymphatics. It's the cellular toolkit for metastasis.
Okay, that makes sense. EMT is the key enabler. Now, that platelet invisibility cloak, that sounds like something straight out of a spy movie. It's incredible. But what happens when these traveling cells, these CTCs, finally reach a new destination? Do they just automatically set up shop and start growing, or is it more complicated? You mentioned some might just sleep.
Right, arriving is one thing, but successfully establishing a new tumor colonization is the final and often the greatest hurdle for metastasis. It's really inefficient. Many, probably most, malignant cells that arrive at a secondary site will actually die off. They might be killed by the local environment or the immune system there, or they just fail to adapt and grow. So failed colonization is the greatest barrier to successful metastasis. It's a really key concept. Those microscopic deposits of cancer cells that manage to survive at the new site but don't actively grow into a detectable tumor. We call those micrometastases.
Micrometastases. Tiny surviving colonies. And that leads us directly to this really fascinating and honestly often frustrating concept of tumor dormancy. What's that about?
Tumor dormancy is exactly that phenomenon. Malignant cells surviving as micrometastases but remaining inactive, essentially asleep, sometimes for years or even decades. They're not actively growing or causing symptoms. When we see cancer relapse years after someone was thought to be cured, it's often because one or more of these dormant micrometastases has finally woken up and started to grow.
What wakes them up? Is it random?
The triggers are really complex and still not fully understood. It likely involves a combination of factors. It could be changes in the local microenvironment at the secondary site. Maybe it becomes more favorable for growth due to inflammation or other signals. Changes in the host's overall immune status might play a role. Perhaps immune surveillance becomes less effective over time. Another key factor is thought to be an angiogenic switch. The dormant cells finally manage to stimulate the formation of new blood vessels, angiogenesis, which provides the nutrients and oxygen they need to start growing rapidly.
Angiogenesis, getting their own blood supply. Okay, this whole idea really reinforces that concept of the seed and soil phenomenon, doesn't it? It's not just about the cancer cell, the seed landing somewhere. The environment, the soil, has to be just right for it to actually grow. How does that play out in where metastases tend to form?
That's a perfect analogy, and it's been around for over a century, but still holds true. The location, the pattern of where secondary tumors form, depends on two main things. First, yes, it depends on the regional drainage patterns, the anatomical plumbing. Where do the lymphatics or blood vessels from the primary tumor actually lead? Often, metastases form in the first capillary bed the cells encounter. But second, and just as important, is that specific interaction between the cancer cells, the seed, and the unique microenvironment of the potential secondary organ, the soil. Some organs just seem to provide a more fertile ground for certain types of cancer cells to colonize and grow.
Can you give some examples of common seed and soil patterns?
Sure. Carcinomas, as we said, often spread via lymphatics first, so you commonly see breast cancer spreading to the axillary lymph nodes in the armpit, or lung cancer to the hilar nodes near the lungs. For blood-borne spread, sarcomas and especially renal cell carcinoma have a tendency to deposit in the lungs because venous blood flows there first. Cancers from the gastrointestinal tract, colon, stomach, pancreas often metastasize to the liver because the portal vein drains blood directly from the gut to the liver. Melanoma also frequently goes to the liver. Other common sites for blood-borne metastases overall are lung, bone, liver, and brain. And for bone metastases specifically, a classic mnemonic is BLT with a kosher pickle. Breast, lung, thyroid, kidney, prostate, those are common primary cancers that spread to bone.
BLT with a kosher pickle.
Okay,
Okay.
that's memorable. So we've covered the origins, the invasion, the journey, the landing. But neoplasms also have these profound ripple effects on the body, don't they? And you mentioned earlier, not all malignant tumors behave the same way. Some seem to have different personalities. That's a very good way to put it. Some cancers, like small cell carcinoma of the lung, are incredibly aggressive and tend to metastasize very early, even when the primary tumor is small. Others, like basal cell carcinoma of the skin, are locally invasive but almost never metastasize. They're malignant, but they stay put. And while larger tumors generally have a higher risk of metastasis, size isn't always the determining factor. A small melanoma can still metastasize widely.
So these tumors exert effects both locally, right where they are, and systemically throughout the whole body.
Exactly. The effects can be wide-ranging.
Let's maybe start with the local effects. What kind of direct trouble can a tumor cause in its immediate neighborhood?
Locally, the problems usually stem from the tumor's physical presence and growth. They can directly invade and destroy the surrounding normal tissue. A classic example is a glioblastoma in the brain causing significant swelling, or edema. They can compress adjacent structures. Think of a tumor in the chest, compressing the superior vena cava, causing SVC obstruction, or a pituitary adenoma pressing on the optic chiasm, causing vision problems. If a tumor grows on a surface like the lining of the colon or the skin, it can ulcerate, break down, and lead to bleeding. That's often how colon cancer presents. They can also block tubes and orifices. A colon adenocarcinoma can grow circumferentially and narrow the lumen, causing obstruction. And importantly, even benign tumors can cause significant local problems just by their size or location. A hemangioma near the eye might affect vision, or a benign fibroma in bone could weaken it and lead to a fracture.
Right, so direct physical disruption. What about the more widespread systemic effects? These often seem more insidious, don't they? Like the tumor is acting like a parasite on the host.
That's a good description. As the total tumor burden increases either from the primary tumor growing or from multiple metastases, it puts a significant metabolic strain on the host. We can think about some of the key systemic impacts using the 3 Cs.
Okay, the 3 Cs of systemic impact, what are they?
The first C is cachexia. This is that profound syndrome of severe weight loss, muscle wasting, loss of appetite, weakness. It's not just starvation. It's driven by factors, including cytokines, released either by the tumor or by the body's inflammatory response to the tumor. It significantly impacts quality of life and tolerance to treatment. The second C is cytokines. These inflammatory signaling molecules contribute not only to cachexia and that general feeling of malaise or unwellness, but they can also contribute to immunosuppression, making the patient more vulnerable to infections. Sometimes cancer can even directly destroy bone marrow, further weakening the immune system. And the third C is clotting. Cancer patients often have an increased risk of thrombosis developing blood clots, like deep vein thrombosis, DVT, or pulmonary embolism, PE. This is due to complex changes in blood clotting factors, often triggered by substances released from the tumor cells.
Cachexia, cytokines, clotting, the 3 Cs. Okay? Now, for maybe one of the most surprising and complex systemic effects, how on earth can a tumor, say, sitting in your lung, cause something like Cushing syndrome, which involves hormone imbalances or even neurological problems that seem completely unrelated to the lung itself.
Ah, yes. This is a fascinating world of paraneoplastic syndromes. These are relatively rare, but they're complex disorders with systemic clinical effects that are caused by an underlying malignancy. And this is the key point, that they're not directly related to the tumor's physical presence, its invasion, or its metastases. They're like remote effects.
Remote effects triggered by the cancer. How do they happen?
They can manifest in several ways, often quite unexpectedly. One major category is hormonal effects. Some tumors can ectopically produce hormones, meaning they produce hormones that aren't normally made by that tissue type or location. For instance, a bronchial small cell carcinoma might produce ACTH, leading to Cushing syndrome, or it might produce ADH, causing SIADH, syndrome of inappropriate antidiuretic hormone secretion. A squamous cell lung carcinoma might produce a PTH-like hormone, causing hypercalcemia, high blood calcium. Even benign thyroid adenoma can overproduce thyroxine, causing hyperthyroidism. Another category is neurological effects. Sometimes the body mounts an immune response against antigens present on the tumor cells, but unfortunately those antigens might also be present on normal nerve cells. So the immune system ends up attacking the nervous system, leading to a wide range of neurological symptoms. There are also hematologic effects, like changes in blood clotting that go beyond just increased thrombosis risk, sometimes leading to conditions like disseminated intravascular coagulation, or DIC, which is a very serious disorder involving both clotting and bleeding. And then there's a whole list of miscellaneous effects: neuropathies, various skin problems, persistent fever, finger clubbing, muscle inflammation or myositis, all potentially triggered by an underlying cancer, even a hidden one.
Wow. So, to explicitly answer that question we posed earlier, how can a tumor in your lung cause something like Cushing syndrome or issues in your brain?
It's precisely through these paraneoplastic syndromes. The tumor, even if it's just sitting locally in the lung, can release hormones like ACTH or other bioactive substances that travel through the bloodstream and exert effects on distant organs like the adrenal glands, causing Cushing's. Or it can trigger that misguided autoimmune response that targets components of the nervous system, leading to neurological symptoms completely removed anatomically from the primary tumor or any metastases. It's the tumor acting at a distance.
That's truly remarkable in a worrying way. It really highlights how cancer isn't just a local problem. And that brings us towards the close of this deep dive. Our mission, remember, was to guide you through this complex world: neoplasms, invasion, metastasis. We went from the core definitions, the naming nightmares, through the intricate cellular steps of spread, and looked at the wide-ranging impact these growths can have. Understanding these fundamentals is just, well, it's absolutely crucial as you build your foundation for clinical practice.
Absolutely. And we really hope the anchors and concepts we discussed today will resonate and serve you well. Things like remembering the irreversibility of neoplasia once it starts, the good neighbor versus bad neighbor analogy for benign versus malignant, those tricky OMA exceptions in MLS GMPA, the DDLM steps for invasion, disconnect, dig, let go, move, the 3 L's and the B routes for spread, lymphatics, local bloods, that incredible platelet and visibility cloak for CTCs, the critical importance of seed and soil for colonization, and those systemic 3Cs, cachexia, cytokines, clotting. Try to keep visualizing these processes as you continue your medical journey. It really helps cement the knowledge.
Definitely. And to leave you, our listener, with a final provocative thought to mull over. Given everything we've discussed, especially the incredible complexity of tumor dormancy and that seed and soil phenomenon, what do you think is the single biggest challenge we face in truly preventing cancer recurrence, sometimes years or decades down the line? And, perhaps more importantly, how might future medical advancements begin to overcome that specific challenge? Something to think about as you continue to learn. Thank you so much for joining us on this deep dive. Keep that curiosity burning, and we'll catch you next time.